is change possible? Meaning, can we become more compassionate? I want to be crystal clear about this. You don't have to be in healthcare to feel burned out. It just so happens that most of the research on burnout has been done in healthcare workers. Leveraging artificial intelligence and technological innovations is key to more human connection, not less. That's an important question, and we could speak for an hour about that alone.
I know.
So here's my answer.
Today in the Leader Seat, we have a truly special guest, Dr. Stephen Trzeciak, a physician, professor, and researcher who has transformed the conversation around healthcare by putting compassion at the forefront. As a co-author of the groundbreaking books Compassionomics and Wonder Drug, 7 scientifically proven ways that serving others is the best medicine for yourself, Dr. Trzeciak has made it his mission to prove that kindness in medicine isn't just a courtesy, but a necessity. Dr. Trzeciak, thank you so much for joining me.
Thank you so much, Nima. It's an honor to be on the show, and I look forward to the conversation.
Of course. I was watching some of your podcasts that you've done previously, and I always see in the middle of somewhere in between the podcast, you say something sarcastically, and the person that's interviewing may not catch it, and you're like, just so you know, I'm fluent in sarcasm, and I love when you said that, because I'm the same way. I'm fluent in sarcasm, and I feel like maybe sometimes in healthcare, people don't catch sarcasm, or they're not comfortable with being sarcasm because we're in such a professional environment. How has that personality trait of yours been you were able to implement in your practice during your rounds with your students, with your patients?
Thanks for that. I'm glad at least one person likes my jokes. So I actually try to avoid it, to be honest with you, because I know that in connecting with people, my way of joking, maybe sarcasm, it's often not helpful in the clinical realm.
Yeah.
And so there's an old saying about the taming of the tongue, right? And so I have to be very mindful all the time that while I may be fluent in sarcasm, that when I'm speaking to my colleagues in the context of whether it's my ICU practice or being chair of the Department of Medicine here at Cooper, I have to be very mindful that sarcasm isn't always the right approach for many different audiences.
Yeah, I feel the same way. I unfortunately thrived even in school and during rotations and stuff. I never brought it up because I was like, I might be sarcastic in a way someone might take it the wrong way, and it just it goes downhill from there. So I'm with you on that. Now, compassion, what you know best, what your research is about, what you've been studying for the past couple of years. Do you think that more people are stuck doing what they don't love these days, and that's why we lack that compassion part?
So it's an interesting question. I think, let me start by saying that I like to look at familiar things in unfamiliar ways. So I'm trained as a physician scientist. I'm trained to generate hypotheses and develop specific aims to test those hypotheses. And over the years, what I've done, while it may look like a pivot from my early years in studying resuscitation science in the ICU, I try to apply those approaches to the questions that are the most important and the most meaningful. And so our first question, along with my colleague and co-author, Dr. Anthony Mazzarelli, Dr. Maz, as we say, we ask the question, does compassion really matter? So there is evidence for a compassion crisis broadly in society as well as in healthcare. But I think a pivotal first question is, does it really matter? Is it, as you say, just a courtesy, or is it a necessity? Or is it just something that's meaningful, or is it really measurable? And I think before we talk about the causes of a lack of compassion, pivotal, if you will, first question is, does it really matter? Because if compassion's just a cherry on top of the sundae, rather than something that's vital for good healthcare and good medicine and for healing, then, perhaps it doesn't even matter that much. And so what we've done in our work is to take all the evidence and use a quasi-systematic review approach and meta-analysis of sorts to synthesize the evidence about the importance of compassion. And once you see that signal, then you get very concerned about the question that you're posing, which is, why is it there? First of all, and we can talk about all the evidence, behind a lack of compassion. I think that it is spilling over and into healthcare from a lack of compassion in society more broadly. Mm-hmm. So I don't know that it's from a lack of doing what it is that we want to do. I think it's multifactorial. I think it's more complex than that.
Yes, the question is, is compassion necessary? Does it really matter? Is it naive to think that obviously, yes, of course it matters. Why is it such a thing that it needs people like yourself to do the research to prove that, compassion is actually meaningful and it matters and has an effect?
Well, I think we've historically relegated compassion to a domain of emotion or an ought, like a moral, ethical imperative, rather than examining it with the same rigor that we examine everything else in medicine, like the medicines that you'll be prescribing or giving to your patients later today in your role as a pharmacist. I think that we've gotten away from putting the necessary rigor on to compassion like we do in all other aspects of medicine. And once you examine compassion through the lens of science, rather than a moral, ethical lens or an emotional, sentimental lens, and then you see the signal in the data, then you know that compassion matters not just in meaningful ways, but also in measurable ways. And when you see that signal, then you feel differently about your opportunities to treat patients and their families with compassion, because you realize that you're wielding something that's actually very powerful.
We're in an era, like innovation, technology, AI, and that's something you posted on LinkedIn earlier, and you said that there was a study that showed that ChatGPT showed more compassion than real doctors. And I thought that was interesting. What is your thoughts on, do you think we'll ever get to a point where there's a robot or an AI that can show the compassion to a patient more than a real physical breathing human being?
So what I actually exposed about that paper, and it was very well done, is that it wasn't comparing a computer, right, to a doctor. It was just analyzing text generated by a doctor versus text generated by ChatGPT in an online Reddit forum. And so what was preferred was the ChatGPT generated text, but that's not surprising because it was also substantially more detailed and longer than the responses from actual physicians. That's not surprising. The physicians that were responding were probably really busy people and couldn't generate such a detailed response. The reason why, so first of all, the headlines in the mass media got it wrong, as they often do with research studies. But number two, we ought to leverage AI to give patients more detailed answers that they want, to give them more material. We use it as a tool, just like we might use other tools in the healthcare domain. And I want to be clear that I believe that leveraging artificial intelligence and technological innovations is key to more human connection, not less. Now, that may sound a little bit counterintuitive, so let me explain. When electronic health records, for example, were developed, it was seen as a very important innovation, which of course it is. It helps to keep patients safe, but there was an unintended consequence. The unintended consequence shows very clearly that healthcare providers, nurses, pharmacists, physicians spend more time looking into computer screens than looking their patients in the eyes. That was not by design. That was an unintended consequence. And so in order to handle that unintended consequence, we actually need more technology, not less. So now we have innovations that can actually listen to the interview between patients and providers and generate a note. And by the way, how it differentiates chit chat from medical information, I have no idea. That's not my area of expertise. But it can actually help us by generating documentation so that we can spend more time doing what Dr. Maz and I call eyeball time, and that's looking our patients in the eyes. Think about all the emotional cues that you might miss from a patient if you're not looking them in the eyes, and how I personally think of that as a public health problem. So it's more technology, not less, that will give us more of what we really want, which is actually talking to patients rather than typing into a computer screen. And further, I would say that what differentiated when I went to med school, so this was the early 90s, when I went to medical school, clearly one of the discriminators between physicians, among many, was your fund of knowledge, right? What you know, how you score on the exams, that would determine what type of residency you might get into. These are how we differentiate ourselves. It will soon become a reality that the answer to everything is at the one touch of a button away. And so when that discriminator among providers is no longer there, meaning it's leveled the playing field to a great extent, then what will differentiate physicians, good physicians versus not so good physicians, pharmacists versus not so good pharmacists, nurses, it will be our humanity. And so I actually think that with AI giving us all the answers, and of course you have to know how to interpret the information, and so there will always be a intellectual component and fund of knowledge component, but I think our humanity will begin to differentiate us more as the technology evolves. So I think our humanity will matter more, not less.
I think you put that so perfectly. Like, I totally believe that, there's things, people that are not in medicine, there's things called up to date, you can put in there whatever you want, and it will give you a general idea of, you don't have to memorize everything. And I feel like in school, when you're in pharmacy medical school, you're trying to memorize every single little detail for the test, knowing that, at some point, you're not going to be able to remember everything that you studied. And at some point, you might have to rely on technology to, bring back that spark of memory where you studied it. And I think we need people like yourself. These machines, innovations, AI, they have to be programmed by human. They can't be programmed by computers, right? And we need people like yourself that have done studies on compassion to be able to help program these AI technologies to be able to teach them how to be compassionate, if we want to say in that way. Competition, we're like I said, you went to medical school, I went to pharmacy school. I'm sure there was plenty of competition in your class, and likewise on mine. And I think going forward till the end of life, there's always going to be competition in professional schools. Do you think competition can have a negative effect in decreasing people to give compassion because they're so focused on being better and being better than the next person and doing better that they forget about the basics of being compassionate?
No. Okay. I think you frame it as competition, and I view it sort of as credentialing, right? So everybody's got to get their credentials, their bona fides, so to speak, to make sure that they have what it takes to do the job. The competition, as you said, whether it's standardized tests and things like that, I recognize that sometimes those things are viewed in a poor light. I don't really see it that way because what they are is predictive. So, for example, you have to have a certain MCAT score to get an interview at my medical school, Cooper Medical School, Rowan University. Why? Is it because we don't want to read a substantial proportion of the applications? Of course not. It's because there is a cutoff, a discriminator that predicts very well which students will or would not struggle with further credentialing examinations, step 1, step 2, step 3, boards, those things, right? So that type of, those discriminators are always going to be important because you have to have your credentialing, you have to have your bona fides. That said, once you have them, what will discriminate who's a good, effective physician versus not are largely going to be all the things that you're talking about right now. One's humanity, how much they are able to know their patient as a person rather than just a constellation of problems. So when I interview medical students, for example, and I'm not part of the admissions committee, but I do participate in evaluating these students, and I serve as what they call a blinded interviewer. So I don't know anything that's in their packet. I don't know their data. I don't know their board scores. I don't even know where they went to college, let alone their grades. I just try to ask myself one question: are patients going to connect with this person? Are the patients going to like this person? And it is those in those capacities are the ones that I'm evaluating, because ultimately, all your credentials and all your test scores and those things don't matter if you don't know how to talk to patients.
How much weight does that have on that? I guess I know you say you're not part of the committee, but how much weight does that have in the decision making?
So in order to get to sit in the chair, so to speak, you have to have your numbers.
Okay.
You got to make your numbers.
Of course.
And we insist upon that because you need to be able to be successful at the next step and the step after that and the step after that. I mean, every 10 years I have to take, I'm more than 20 years out of training now, but every 10 years I have to sit for that board exam, right? And so we need to make sure that people are not going to struggle in those steps. But that said, the people that can make those numbers is a big group of people. So a lot of the human factors, as we say, are the things that are going to discriminate who we actually want to take or not.
Do you think that standardized exams may not be the best way to, I guess, accept people? I understand what you're saying, like they need to pass a certain thing to be able to not struggle. But do you think that there might be, like, if someone's so good at patient interaction and just are very good at that part of it, but they're just struggling a little bit with the academia, they could always pick up the academia and learn it. Even during medical school, there's 4 years in that, and then there's residency, there's training. They might be struggling now, but they might pick it up later on. Do you think standardized exams do a good job of capturing the right people to bring in?
I think they do what they're intended to do. And that is to be a bar that you need to get over in order to take the next step and the step after that and the step after that. Because, as a pharmacist, when you'll be working clinically later today, as you shared with me before we started, there are certain things that you must know to keep patients safe, right? And you have to have your credentials, you have to have your bona fides. Plus, in addition to that, we want somebody that cares deeply about patients, sees them as a person, not just a constellation of symptoms. It's not an either or, it's an and. You have to have both, right? You have to have both. Not everybody is cut out to have both. There are a lot of things I'm not cut out for, okay? I wanted to be a basketball player when I was very young. The problem is that I'm actually terrible. Now, that I never let that stop me, right? But clearly I was not cut out for the NBA, right? There are a lot of things I'm not cut out for. it's not an either or, it's an and. You have to have your academic rigor, you got your credentialing, your bona fides. You have to know what you're doing, and you have to treat people with compassion and connect with them on a human level. It's not one or the other, it's both.
So off of that, I'll give you my personal opinion. I think it's harder to teach someone how to be compassionate versus teaching them how to study and learn material that's in a book. Do you think that you could teach someone how to be compassion, how to have compassion, how to be human, how to treat people, or do you think that that's something you have to be born with? And also, do you think how you were raised, who your family were, who your friends were, who you hung out with, have an effect on you being able to learn how to be compassionate?
So what I often tell people is I don't tell you what I think. I don't tell you what I believe. I don't tell you my opinion. I'll just tell you what we've found in our journey through the scientific evidence. And I like to be evidence-based in everything I do as a physician when I'm practicing in the ICU as an intensivist. I also like to be evidence-based when I'm teaching. I like to take an evidence-based approach when I'm leading the Department of Medicine as the chair of medicine here at Cooper. And similarly, I'll take a evidence-based approach to the question you just asked me. And really the question, if I just would frame it slightly differently, is change possible? Meaning, can we become more compassionate? The answer, quite clearly, both in the healthcare domain and just broadly across psychological science, is that we can, in fact, learn compassionate behaviors. Change is possible. Now, that's not a pithy bumper sticker, okay? That is supported by dozens of very well-conducted research studies published in peer-reviewed scientific journals. Now let me put some detail on this. It is thought to be true by the scientists that study this, that there may be some genetic component of our ability to connect with other human beings. That's probably not too surprising to you, but the scientists that study this believe that it's about 1/3 of our capacity. But what that translates to is about 2/3 of our capacity then is not nature, but nurture, so to speak. And so our group here at Cooper, led by my colleague and our science director, Dr. Brian Roberts, did a systematic review and qualitative meta-analysis of all of the studies published in the literature. This is a study published in the journal PLOS ONE about 3 or 4 years ago. What he found is that there have been 54 studies published in the scientific literature about curricula for empathy and compassion training for physicians. And of those, 75%, so the vast majority, 3/4 of the studies, found that they did move the needle in some way in compassion for others, and that includes from the patient perspective, okay? And so the key word is behavior. So it's compassionate behaviors can, in fact, be learned. You may be familiar with the work of Dr. Carol Dweck and her colleagues at Stanford University who've studied the growth mindset. And they've studied in the context of kids coming up through the educational system. And they found that kids who had a fixed mindset, meaning they believed that their intelligence was a trait rather than a collection of skills, those kids with a fixed mindset, when they would experience some sort of failure, some struggle, they would internalize it and they would give up much more easily and they would have poor performance over school. But the kids who had a growth mindset, they saw their intelligence not as a trait, but as a collection of skills. And therefore, if they experienced some struggle, they just had to work at those skills a little bit harder. The kids who had a growth mindset were the kids who would put in the effort to overcome struggle and ultimately were more likely to experience success in their education. What many people don't know about Dr. Dweck and colleagues' work in this space is they've also studied this for compassion, and they found the same results. Meaning, those people who view compassion as a trait might say things like, well, I'm not touchy-feely, or I'm not like that, right? Those are the people who will not put in the work when compassion is hard. And let's face it, sometimes compassion is really, really hard. However, what they found is that people who have a growth mindset about compassion for others and realize that there's a collection of skills rather than a trait, those people will put in the work, especially when compassion is hard, and those people will get better at showing compassion for others over time. So if we want to be evidence-based about this, we must realize that we can, in fact, get better at our compassionate behaviors, how we behave towards other people. And that is good news for me indeed, because I am just a work in progress. And I don't get it right all the time, even after studying compassion science for many years now. But I work at my compassion for others just like, excuse me, I work at my compassion for others in the ICU, for example, just like I work at my skills with endotracheal intubation or pulmonary artery catheterization or any other procedural skills. I don't get it right all the time. And I look for others for examples of how to get it right, especially the nurses who I've worked with now for 20 plus years in the ICU. But we can, in fact, get better over time. The key is that we have to believe that we can, in fact, get better. That's not a bumper sticker. It's called the growth mindset. It is evidence-based. And thankfully, science shows that we can, in fact, get better. What our group here at Cooper is now studying, and we have a grant from AHRQ, Agency for Healthcare Research and Quality, where we are testing behaviors from the patient perspective and their association with their overall experience of clinician compassion. Because I want to science this up. I don't want students to be taught by a senior physician who's always known for connecting with patients. You know, here's how I did it in my experience. That's like the apprenticeship model. And we can continue to do those things because I think that those examples are very important and they're formative for physicians in training and medical students especially. But I think we can do better than that. In addition to exposing them to people like through the apprenticeship model who have always had a good, quote unquote, bedside manner, we also need to get evidence-based about it. And we can actually calculate odds ratios for each individual behavior and its likelihood for impacting the patient in their experience of compassion from a caregiver. And those behaviors may be different for different people. For me, it might be different than somebody who's much younger than me or had a lot of life trauma when they were young. Like the behaviors may be different depending on what the patient has been through and what they actually need.
I think the way you're approaching it is the right way and the perfect way, having the evidence base behind it, because the topics of compassion or empathy or respect or honesty, like these things, everyone can speak on from a personal perspective, right? We've all had some sort of relationship or cross paths of feeling these feelings or coming across people that are super honest that affected us, or respect. And people always, talk about respect and honesty, but you're putting, the data behind it, which makes it harder for someone. If they wanted to argue to your point, you'd be like, well, listen, these are the numbers. Like what you just said when I asked the question, you're like, it's not my opinion. It's not what I think. I'm going to tell you what the data is. And it makes it a lot more credible when you do it like that. It makes it go a lot further.
Well, I appreciate those kind words. You're very generous. I am unapologetically me. Okay. So I've been trained as a physician scientist. I don't have the eloquence that many of my colleagues who teach medical students have. What I have is experience in constructing hypotheses and using methodologies to test those hypotheses. So I'm just going to stay in my wheelhouse, so to speak, because that's what I know how to do. There are people that disagree. To be fair, there are people who disagree with me,
But that's
you can't. I just aim to use data to show that they're wrong.
I truly do believe that if you do what you do, anyone, and if no one is like arguing the other side, then what you're doing is just not right. Like you should just move on to the next thing. So as long as you have someone arguing the other side, you're doing the right thing, and you're sparking that interest or conversation in people's minds.
But that's also when my sarcasm comes out,
Yeah.
right? So when a colleague of mine says, "Well, I think that this is, a bunch of bull," I don't think you can. I don't think that you can measure these things.
Yeah.
That's when, as much as I try to, or I believe in taming of the tongue, my sarcasm comes out, and I say, "Well, exactly which of the 250 original science research papers cited behind this work, which of those 250 original science research papers do you have a problem with?" Right?
I love it.
That's not the most effective approach.
No, I love
usually
it,
to try to convince somebody. Anyway, So we try to use Dr. Maz and I. That is, we try to use data at least a semi-quantitative approach, where other people have always put it used qualitative approaches. And by the way, I think qualitative research is super important, especially in testing the impact of compassion on patients. And we're getting into that a little bit here in our research program here at Cooper. But we try to put data to things that historically other people have viewed through a different lens.
Yeah, I think that you're always going to have the people that go super left field and disagree with you and with some nonsense, right? But I think it's healthy to have the middle ground conversation back and forth of people that have the other end, because that can also spark something in your mind to go research that part of it that maybe you weren't thinking about. You spoke about compassion in the ICU, and I was watching one of the podcasts you did, and you mentioned something like you were in the middle of rounds, and this patient, he was having a hard time eating his breakfast, eggs, and you saw it in the side of your eyes, and you went ahead and, long story short, you helped the gentleman eat his eggs. And then when you came back, the one of the students that was with you during rounds was like, Dr. Trzeciak, like, you don't need to do that. We have people to do that for you. Now with social media and everything, and you're obviously doing podcasts, you've done a TED Talk, do you see more of your students coming around that know your work and know what you do? And are you attracting, I guess, more compassion through the students from your work? Do you see that people coming on know your work? Because clearly that student no way knew your work to say something like that to you.
So there are two important components to your question. I want to make sure that I address both. One is, what was I talking about? What is this all about? You're aware of all the research on burnout,
yes,
right?
Yes.
I want to be crystal clear about this. You don't have to be in healthcare to feel burned out. It just so happens that most of the research on burnout has been done in healthcare workers. And so that's just the population in which these hypotheses have been tested. But there's nothing specific to working in healthcare about burnout, especially after years of a pandemic. I mean, burnout is everywhere. And whether the folks listening to this podcast are in healthcare or not, anybody can be burned out. There are three distinct domains to burnout. One is emotional exhaustion. Two is depersonalization. So that's an inability or difficulty making personal connections. The third one is a feeling like you're not really making a difference. In healthcare, in medicine broadly, there are many times you will encounter patients and their families where you cannot change the outcome, right? So let's say they've got, in the example that you're talking about, it was a man with a terminal condition for which all treatments had been exhausted. There were no treatments. So oftentimes we think, well, I can't really make a difference. That's false. You just haven't asked the patient what matters most to them. If you ask the patient what matters most to them right now, or what worries you the most, you can find ways to make a difference for that patient, even though it's not going to change the fact that it's a terminal condition. Does that make sense? When you focus on being able to do those things, and in this case, I was just trying to help this poor guy eat after he had been on a ventilator for 10 days and was incredibly weak and even unable to feed himself. When you focus on those things and making those differences for patients, that builds resilience and resistance to burnout, because you know, because you experience it, that you can actually make a difference. And so what I tell students, residents, fellows, anybody that will listen, is just look for those little differences you can make, even if it might not change the eventual, final outcome, as we say, and focus on those things. And if you do those things and you experience how meaningful it is for another person, and I'm sure you've had experiences of this as a pharmacist, right? Doing things that are meaningful for them, but you won't know what those things are if you don't ask, if you don't get to know them as a person. So 2 questions that are evidence-based that I often ask patients and their families. Number 1 is, what worries you the most? And as I've built into my practice the asking of that question, I've been blown away by what people say. But it also uncovers a bunch of opportunities to make a difference for somebody. Another question is, what matters most to you right now? It might not be the things regarding what we think are the final outcome. It might be something quite different. And if we ask those questions, we will get to know people as get to know our patients as a person, rather than just a constellation of symptoms or signs and symptoms. And we'll uncover all sorts of opportunities. The other thing that you asked me about was, does a certain sort of student gravitate to this work that we're doing here at Cooper? Well, we have something that's I consider to be very special. So Dr. Ed Viner was the chair of medicine, 3 chairs of medicine before I had the opportunity and the privilege to become the chair of medicine. And our Center for Humanism is named after him, the Viner Center for Humanism. It is a crown jewel of our medical school here at Cooper. And the work that Dr. Viner and his colleagues, and I collaborate as well, that work is not exclusive throughout medical schools in the U.S. There are other schools, of course, that have important efforts that are similarly aligned, but I just think that we've got a really special group of people working on what we're talking about here today, and it does stand out, and it does attract a certain type of student, a student who not only has the bona fides, right, the test scores and the ability to achieve academically, but also wants to treat patients as they ought to be treated, the way that we would want to be treated ourselves.
So you spoke about burnout. Do you think that the word burnout is being abused a little bit? And what I mean by that, like, I feel like maybe people at work say they're burned out when they're not really burned out, and the word burnout is making people lazy, maybe. And then with them using it without really understanding what burnout really means, because it's so publicized. Like, if things get a little hard, oh, I'm burned out.
I understand the question, and I appreciate it. I'm okay with it. And the reason is because when I was in medical school, this again was the early 90s, you were not allowed to admit any weakness whatsoever. Right?
Yeah.
If you had been up all night on call and you still had an exam the next day or whatnot, I mean, there was no safe space to discuss that you might be struggling, whether it's with physical fatigue, emotional fatigue, other things that may be affecting you in your life. Perhaps you have a personal family matter that's really heavy right now. We weren't we're all supposed to be, impervious to these things. And I'm okay with the dialogue because I don't think that was a helpful culture. I understand what you're saying, but I think it's important that we're able to express when we're going through a tough time and maybe need to take a breather or need to lean on our colleagues or friends and family for support.
Leadership, I think, is something that's super important, and it's been a hot topic for the past, I don't know, decade, and it got even hotter after the pandemic. There's different type of leadership styles, right? Yourself are a leader at the medical school in the hospital. How do you see leadership having an effect on the employees and how much they show compassion? Like, what kind of leader leading the tribe, leading the team, who they are, what they believe in, how they speak, how they treat their colleagues, how much effect does that have in the provider going out under the front lines and showing that compassion?
That's an important question, and we could speak for an hour about that alone.
I know.
So here's my answer. There's an old saying about leadership, and it rings true for me as I progress. I was head of critical care before I was the chair of the Department of Medicine here at Cooper, and have about 300 or so physicians that are in my department. The old saying about leadership is this, and I think about this on an almost daily basis. Leadership is not about being in charge. It's about taking care of the people who are in your charge. So it's not an elevation in terms of an accolade. What it is a deep responsibility to take care of these people. And many people would put that into a category of what they call servant leadership. I think that framing it that way is helpful for effective leadership. My job in being the chair of medicine is to block and tackle for, all the different division heads and physicians in my department so they can go do what they do best, which is take care of patients, teach the next generation, develop new innovations for discovery and for research. And so that's how I see my role. I think that just like with everything I do, there is a rich evidence base behind it, and we're in the process of curating all that scientific evidence now. But if we treat each other the way we would want to be treated, so it's not just compassion for patients and for their families, it's also compassion for each other and how we take care of each other. And so everything that I share with you, whether it's through my books or talks or podcasts or whatever, typically has I could put a scientific citation behind it, except the thing I'm going to say right now to you next, which is this, and this is just experiential, okay? If we do a good job at taking care of each other, how we take care of patients will be just fine. And there's robust evidence in nursing, for example. So a McKinsey & Company study from 2 years ago surveyed folks from all walks of life, including in healthcare. They specifically studied nurses, and there was a high proportion of nurses that were considering leaving in the next 24 months, whether it was leaving for another health system or leaving medicine entirely. And this McKinsey study looked for discriminators. What were the discriminators? So workload, of course, mattered to some extent. Pay mattered to some extent. That's sort of intuitive. But they weren't the best discriminators. They were just some of the criteria. The best discriminators were two things. One was having caring and trusting teammates. And number two was a sense of belonging. Having caring and trusting teammates and a sense of belonging. Every health system, including yours, including mine, the number one expense is people. And the churn of people, the turnover, whether they're leaving the profession entirely or going to work for another organization, that is incredibly expensive. And so the health of our health systems, the bottom line, so to speak, is determined largely by people and how we treat people. And so if we do a good job as leaders of taking care of the people who are in our charge, not only do I believe, as I shared with you, I think how we treat patients will be just fine, but also our departments, our systems will be stronger for it, and we'll be able to hold on to those. We in this current environment with a demographic drought, as they say, and shortages of healthcare workers, we can't afford to lose anybody, especially the people who are good. And so leading with compassion is one of the most important things that leaders can do. And there's plenty of evidence behind that as well.
I love that. One last question before we go. I got to ask you a question that you can't answer evidence-based, with evidence-based, and it has to be who you are. So I'm going to end it on this. If we were to go back to high school, college, even medical school, and I was to ask your best friend or your favorite teacher, who was Stephen, what would they say?
I think, so I was a philosophy major in college.
Okay.
I don't know if that's surprising to you or not, but there's some information there and you can do whatever you want with it. I think that I was, and still am, because of that background, that training that I had, I was somebody who always wanted to ask the most meaningful questions. Of course, I didn't have answers to these questions, but what that training taught me is not to shy away from asking those most important questions. And that's what we're trying to do in this work, whether it's with Compassionomics or Wonder Drug or any of our works or any of our research. It's asking the most meaningful questions. And then, so I think they would consider me to be be a questioner and a seeker of sorts. I think that probably shines through in the work that I'm still doing now, decades later.
Were you the comedian in high school? Come on.
Definitely not.
Oh, sarcasm. You got the sarcasm part. How could you not be the comedian?
I think my fluency in sarcasm came much later in life.
Okay. That's fair. Dr. Trzeciak, thank you so much for joining me today. It was a pleasure speaking with you. I'm sure not only did I, but the audience learned so much from our talk, and I'm sure they're going to go Google you more to learn more about your work, and I would love to come back and speak with you. Like you said, the leadership question could be spoken about just an hour by itself, and I think that's an important topic. So I'll leave the last word to you.
I want to thank you for your generous words and for allowing me to be on the show today. So my name's Steve Trzeciak. I teach at Cooper Medical School, and I appreciate your listeners giving me their time today. Your time is your most important commodity, and I don't take that responsibility lightly. So thank you for generously sharing your time with me today.
Of course, anytime. And thank you so much for everyone that tuned in.